So, good morning and good afternoon and good evening to all the members of the Pasteur Network community. Welcome to this new edition of the Pasteur Network Monthly Seminar. Thank you so much for joining us today. We will start with our speaker presentation, followed by the Q&A session. Feel free to post your question during the chat at any time or raise them directly during the Q&A. Please, to ensure a smooth experience for everyone, keep your microphone and camera switched off during the talk and during the Q&A. The seminar is recorded and will be soon available on the Pasteur Network's YouTube channel. Today, our seminar will cover a relatively recent topic that has grown increasingly important in social sciences research, especially since the COVID-19 pandemic. Mis and disinformation, how to mitigate negative impacts on health. And for that, it's our honor to introduce our speaker, Professor Heidi Larson. Professor Larson is a professor of anthropology, risk and decision science, and director of the Vaccine Confidence Project at the London School of Hygiene and Tropical Medicine. She holds a concurrent position as clinical professor at the Institute of Health Metrics and Evaluation at the University of Washington and guest professor at University of Antwerp and KULeuven in Belgium. Professor Larson also previously headed strategy and communication for UNICEF's Global Immunization Programme, chaired Gavi's Advocacy Task Force, and served on the WHO SAGE working group on vaccine hesitancy. She is author of Stuck: How Vaccine Rumors Start and Why They Don't Go Away. In 2021, she was awarded the Edinburgh Medal, and the BBC named her as one of the 100 most influential women in the world. Before handing over to our speaker, as always, a quick word on our platform, PNLink, that you can discover in the shared folder, in the shared screen. So the link is in the chat as well, I think. If it's not, we will add it. So we launched it 6 months ago. We already have more than 1,000 people on PNLink. Many of you here are already registered on PNLink, and we are really thankful for that. So we can discover more and more opportunities across the network. Again, PNLink is totally free and open to all the members, absolutely all the members in the network, researchers, students.
You and me, but
and support staff across the network. So if you're not on PNLink, just take 2 minutes to sign up, create your profile, and connect with the others and develop new opportunities. The last thing I would like to say is that we're creating groups, and for many other fields of expertise, we will plan to create a special group for social scientists across the network to map research priorities, share practices, and spark opportunities. So I know I talked too much, so now I'm giving the floor to Professor Larson. And Heidi, please, the floor is yours. And thank you so much for being here.
Thanks. Let's see. I will share screen. Are we good? Can you see?
Yes, perfect.
Okay, great. Thanks everyone, and I have to endorse the sentiment that this issue of mis and disinformation is not brand new in the world, but the nature and scope of it has become increasingly complicated and important for us to pay attention to. Let's see. Okay. I'm gonna get everybody's pace on the side here. So we've been doing, I've founded the Vaccine Confidence Project in 2010, 16 years ago, because of concerns about growing questioning around vaccines, and founded the Vaccine Confidence Project. And in our 16 years of work, we've seen, and initially it was detect early signs of rumors to be able to respond before they started to disrupt programs, which I had seen a lot of program disruptions in my years in UNICEF, that had we picked up the rumor or the dissent earlier, we could have averted. So that was the mission of the Vaccine Confidence Project, but it was specific to vaccines. When COVID came along, I was lucky to get a MacArthur Award that let me expand beyond vaccines, building on the global network we had established, but asking a lot more about other issues. And that's the Global Listening Project. We worked in 70 countries during COVID, listening to people's concerns. Who did they trust? Who did they turn to? Where did they get their information? But out of all this bigger analysis during COVID, we saw a clear rise in cynicism and actually indifference is the word a lot of people used, that during those few years people hardened. At first they were afraid, and then they got angry, and then they thought they started to get hopeful, but then to cope with it all, people hardened. People started to go looking beyond the official information system. Well, they were already doing that before COVID, but more intensively. The issue of making things relevant and non-elite. This image from the US, I just thought it captured the current sentiments now, which are kind of anti-elite, pro belief, pro emotion. The more you know, KNOW, the more you know, say no. And we actually saw that during COVID in a 15-country study across Africa, to anticipate the acceptance of COVID vaccines that we did with Africa CDC. It was actually pretty high willingness to take a vaccine, but the more they got information about these vaccines, the more the questioning came, the more. So where do we find a sweet spot where you give people enough information, but not too much that would get them concerned, or give them other information to contextualize it and make it relevant to their lives? We've been working on a lot of trust issues and misinformation issues that have disrupted programs. While we, on the one hand, my research group is constantly scanning the horizon for early signals that we can, contact our colleagues in countries and say, listen, this is starting to bubble up. We should think about ways to kind of contain it. But one of them that erupted quite badly and for a long time was in the Philippines around the introduction of a new dengue vaccine. And that became incredibly toxic. The good news is that the Ministry of Health really worked hard at trust building. And in a recent 10-country study, which we did on willingness to take a new dengue vaccine, and that's the Qdenga from Takeda, we did 6 countries in Asia and 4 in Latin America. The Philippines turned out to be the most willing to have the new vaccine. And that's thanks to the Ministry of Health to have put, during this Dengvaxia period, a huge amount of effort. But the point is that you need to make a huge effort. There needs to be an investment. I know we're hearing a lot about Iran in the news these days, but actually during COVID, they were in the news for other reasons. The notion that actually sadly came out of the US about drinking, chlorine, but also all kinds of concoctions to, quote, cure COVID, actually ended up killing people. HPV is another issue. We've seen all kinds of issues with, they weren't even clinical trials, although they were criticized as being unethical clinical trials. There were actually 2 demonstration projects in India in 2010 in 2 different states, and they were looking at whether a campaign-based, everybody come get your vaccine between these dates, versus introducing the vaccine in a routine clinic when people come in, They learn about it, they're asked about it. Just comparing two kinds of delivery. Anyway, there was a lot of resistance locally. Now, this is an interesting example because the local community engagement was like textbook perfect. The resistance came from Delhi, which was far from the two more southern middle states, and a anti-big business communist member of parliament in the Calcutta state where Calcutta is. And they were, and it was women's groups, arguing with the government that you shouldn't be working on introducing very expensive new vaccines when we have no screening early. And why are you doing this big thing with Bill Gates and business? And so it got totally disproportionate to what the issue was. Still today, they're struggling to get the HPV vaccine introduced. They have, in different states, have taken an initiative. But again, one of the new challenges we have is that we finally went from top down to recognizing the importance of community level engagement, which still is important, but we also need to keep our eyes on the horizon. Things can come from far away, another country, another part of a country, and disrupt. So even with strong local engagement, you need to keep your eyes on the horizon, particularly social media, but not only. We looked, another issue that happened was out of Japan. 12 girls had what WHO has since named immunization stress-related responses. They didn't want to use the word psychogenic because it's become stigmatized. But the parents of these girls were videotaping and sharing on YouTube these images, which there was a knock-on effect globally with anxiety among young girls. We saw a film called The Vaccinated Girls in Denmark, UK, France, Norway, Ireland. After we did this, these images went to South America. They were subtitled in Spanish. And in Colombia, nearly 500 girls across different settings started fainting because of these circulating YouTube videos. So that's an example of, you can be well engaged locally, but things can come online and create a bit of a shock in the system. We also did a global scanning between 2016 and 2017 of all online news articles that mentioned Andrew Wakefield, who had made the suggestion of MMR vaccine being linked to autism. And this is how far that has spread, and that sentiment has spread, which is pretty, this is in the course of 10 years, but it was virtually global. In this environment, and as I said, it escalated tremendously during COVID. Our usual monitoring, both online news and social media, as well as other types of survey work, we saw a dramatic increase in the groups who started to get engaged in questioning, in particular in vaccines, but started to get together around a bigger sentiment of anti-government control, of anti-elite, of anti-global government control, this anxiety about globally they're controlling us. And it really brought together groups that didn't typically connect, but came together under that shared anti-government control, freedom of thinking, freedom of choice, from bringing together anti-GMO, questioning vaccines, far-right groups, pro-populist. It was pretty dramatic. And this captures some of the just specific to vaccines, although there were other health areas and interventions affected. You can see the decline in confidence in the safety of vaccines. Let's see. The UN last year, last year released a global risk report, and with from 136 countries, surveys and interviews, and what they saw was, sorry, I'm trying, somehow the faces of everyone keep coming up in front of the screen. Okay, oops, hold on. Can you still see, or did I stop sharing?
No, you stopped sharing.
Okay. Can you see now?
Yeah.
Is it the interviewed across 136 countries?
Yes.
Okay, great. So mis and disinformation was the number one risk globally, and that's across 136 countries. That are the perceptions, public perceptions, above climate change, above large-scale pollution, above geopolitical tensions. That's how big the anxiety and perception of mis and disinformation is. They created this landscaping, which I thought was quite interesting, but you can see that there's much more anxiety about mis and disinformation than new pandemic or biorisks, and other issues. Of course, it's never out there on its own. It's always combined, and the World Economic Forum also did have their annual risk report, and this is 25-26. This was just from January. And although these are all a cumulative amount of risks that were cited, mis and disinformation was right at the top. I thought this was really an important figure in the WEF risk report, because what it does feature is that while mis and disinformation was across the board, across different areas from economic, environmental, geopolitical, technologically, it shows how strongly it's tied to societal polarization, inequality, decline in well-being. So when we're looking at how do we mitigate this mis and disinformation, we have to look at the context, the societal context, the issues that they're situated in, because sometimes that's what we have to try to address before we can neutralize, as it were, mis and disinformation. We need like immediate tactics, but while we recognize what are the underlying factors that are driving the dissent, the distrust, the appetite for mis and disinformation. What I thought was interesting about the World Economic Forum's analysis is they also disaggregated it by age. And in our 70 country study during COVID, we also disaggregated by decade, and I think it's so important. We often tailor our health interventions socioeconomically and by different groups, but not enough by age cohort. In this case, for instance, the under 40s were the most anxious about the impact of mis and disinformation. And then everybody above 40, it was only second after geoeconomic confrontation. So you can see, and we've seen in our 70 country study, that the age group of 18 to 35 was particularly came out of COVID particularly angry, particularly hardened, particularly feeling that they paid the price for COVID. But at the same time, they're also starting jobs, feeling lost educational opportunities, have angst about opportunities in the face of AI. So I do think that we do need to tailor, and also there's different literacy and ways of communications more than ever across these age groups. What I thought was interesting in another study and group that we work closely with is the Edelman Trust Barometer. They found that, and this is a smaller group than the 136 of the Global Risk Report, but it was a significant enough. I think they had 36 countries. That age group, 18 to 34, had the most regret due to decisions made due to misinformation, more than the older groups, which I thought was interesting because the consciousness about it is really important. Because if they didn't have that consciousness, it wouldn't kind of change thinking and behavior. So that's an important thing. But it does see, and we've seen this with more adult vaccinations and health interventions, the older age groups are more trusting of things like social media and not as aware sometimes, particularly older, tend to trust things that 18 to 34 have a consciousness that you can, a much more visceral consciousness of the risks. I don't want to get into too much theoretical stuff here, but there's I think one of the best models and frameworks out there for looking at risk and management of risk came in around the risk science when it emerged around the nuclear energy and all the things, and how publics had a much more disproportionate perception of risk relative to the actual technical risk. And that's very true in the health field. When there's a small risk, the society will amplify it, and understanding how it's being amplified and where it's being amplified individually, social networks, professional networks, government agencies, looking at all that is really important. And really our biggest thing, and we've updated the social amplification of risk framework in the context of newer technologies and social media and increasingly AI. So that amplification factor is a big concern. So when we're thinking about how are we going to, trust and risk and rumor are all hyper-connected. So what we're seeing is it's important to not only try to identify and sort of ring vaccination with accurate information, misinformation as it emerges. It's very related to trust levels. And I often talk about what is the fertile ground factor for mis and disinformation, because if we don't deal with that, we can be like clipping the leaves off, but not dealing with the roots, so to speak. So one of the things we looked at a lot is in the 70 country study, who did people turn to? Who did they trust during COVID? And I know a lot of the media says that people don't trust science anymore. The reality is it's not that they don't trust science, is that because over 70% trust in science is not that low in some of these countries. But the reality is, and this particularly happened during COVID, people turn to a lot of other sources than they might have. So they still have some trust in scientists, and particularly their family doctors were very high. That didn't come up in this Nature article. But so the point we're saying is it's not just about loss of trust in science, it's loss of influence on the part of science against a lot of others who are competing for attention, so to speak. Different sources, different influencers, family, friend, religious leaders, community people, social networks. And we do have the data for 70 countries on this stacking. Oops, let's see. I've just tried to, sorry, pull up from the 70 countries just to give you a sense with a broader spectrum, which we couldn't get into the Lancet article from a space perspective. But you can see the green ones were who were the trusted the highest out of this science, religious leaders, community, friend, family, and family doctor. Yellow was second, or blue was second, and then the yellow was third. But you can see the strength of community leaders and family doctors were very strong. So why do you care? Well, these kinds of insights help you target where the intervention is needed, understand where the influence is coming from. So when misinformation comes up, you know who to work with. The problem is when it is a community leader or a religious leader, and even sometimes we're seeing things come up with family doctors who think differently than mainstream science. That's when it gets even more complicated. So the influencer, the fertile ground factor, and the piece of misinformation itself. I think one of the challenges right now with misinformation is the issues are not just about misinformation. They are about amplification of a real but very small risk. So it's not really misinformation, it's distorted levels of information of a real risk. And also there's a lot of manipulation of emotion, fear mongering, anxiety creating, but it's not really misinformation. So if you have a lot of criteria in your social media system or in your publications or whatever, however you're communicating, that's only looking for facts, making sure things are facts, and not paying attention to, well, what kind of emotion does this evoke? What kind of, how will this influence people? This was just, I thought, an interesting diagram that was in a paper that really looks at how much rumor generation and trust levels are interrelated. To me, risk and trust are two sides of a coin. The more trust you have, the more willing you are to tolerate a little bit of risk. But if you have low trust, a little risk becomes a big risk. Let's see. So when you're trying to mitigate or address this misinformation, in our experience, we have three types of three things that really we think matter. Risk mapping of where the most vulnerable population to misinformation. We often talk about misinformation susceptibility, and based on historic experiences, distrust. We have been running for 10 years a vaccine confidence index, so that also gives us a signal, even beyond the vaccine, because we find that trust in vaccines also reflects trust in government, trust in authorities, so that's also another window. But if you're about to introduce a new health intervention in a setting, or you're going to start a clinical trial, the kind of things you want to look for outside of the logistics is, has this community had some historic experiences that we should be aware of? what's the trust levels here? Are there particular people that are known to be disruptors? You need to get that kind of risk mapping before, so you know where you're going to need to pay more attention. Don't wait for a problem to say, oh yeah, we should have paid attention to him because he was a problem in a trial 3 years ago, or that part of the community never wanted to take vaccines, so we should have paid more attention to them when we introduced this trial. So the mapping of the susceptibility factors, the vulnerability factors, and then, having a system in place for listening for new and emerging rumors. When we led a 5-year initiative with the EU on managing trust and rumors around clinical trials around Ebola vaccine candidates. And it was a mix of some social media monitoring, but really having people identified in the communities where the trials were to be the community listeners and to be someone that, we had regular communication with and who was, known in the community. They would go to him or her if they heard something. There are different ways you can do it depending on the setting you're in. I mean, that was in a very remote area of Sierra Leone along the Guinea border. But, in other settings which are very internet saturated, or you will probably have more focus on the online. And then trying to get a handle on local networks of influence and influencers. Now, a number of you, I think all of you have been in settings for a while to already know some of these things and are important to keep that awareness or understanding alive. Part of handover with new people coming in, these kinds of briefings are really important. They're not given enough attention and are more important than ever in the current environment we are globally. Also, I think involving people from the communities in the monitoring, not only locally, but outside, online. This was an initiative that UNICEF did around some of the polio rumors, and it also gave a role for some of the younger people to be involved, and it was really very effective. I had mentioned we had worked on a number of clinical trials, but even before we were doing the work in Sierra Leone, and that was more already phase 2 for I'm sure you're aware of, 2 phase 1 Ebola vaccine trials in Ghana were suspended because of a rumor, and this was not a social media rumor. This was a diaspora Ghanaian in the US who called a friend or colleague of his and said, listen, I hear that they're recruiting in the maternity wards candidates for an Ebola vaccine trial. And his friend was a radio producer, so it went to the radio, then it went, and then there were some independent groups, resistance groups that used this, and it just went wild. So if you go onto our website, the Vaccine Confidence Project, and look for this is a 10-minute video. After we had done a lot of research on this with collaborators on the ground, we did a 10-minute video going around and interviewing pretty much everyone we could find, from the radio producer, the people in parliament, people in the regulatory village leaders, the independence group. We didn't know if anyone wanted to talk. They all wanted to give their point of view. So it's a really interesting 10-minute window on how one telephone call can turn a whole situation upside down to the point it became a huge parliamentary issue in Ghana, and those 2 trials were suspended. Out of the work we had done, this was a guidebook that might be interesting. There is a section on rumors, but I think the overall guidance on community engagement and new technologies in outbreak settings, we realized that there was a lot of there were a lot of resources out there on community engagement in general in health, but not specific to how it's different in the context of clinical trials. So it should be an interesting, and you can find that online. We're also coordinating with a group of other academics, what we're calling the IRIS Research Group, and we're really focused on studying and understanding infodemics and ecosystems and working collaboratively with others on developing strategies. It's a really great initiative, and we want to expand on it. As Hisham mentioned, I wrote a book which actually came out in March 2020 before COVID, even though the last chapter is on pandemics and publics. Just to show you that these are the chapter titles that for rumor, so the first chapter is on rumor, because I also talk about rumors. Rumors are not all bad. Misinformation is a different framing, but a rumor is an unverified piece of information. It might actually be true, but when it's in a rumor state, it's still unverified in principle. In the basement in WHO, they have all the archives of smallpox rumors, for instance, because they were listening, particularly towards the end when we were nearly eradication. They were listening for rumors of any possible signal of a remaining case globally. I also talk about dignity and distrust as being part of, what can make people resilient or not, on risk and volatility of opinion. That's how quickly people's opinions are changing these days. You can think they're on board, and then a week later, something came across their screen or through the, as we call it in the South Pacific, the coconut wireless, they hear something, change their mind. Anyway, this is our website if you want to find more there. And I will, sorry, I went a bit longer, but I think we got started a bit later, just so
that's
time
perfect.
for some questions.
The things when you're perfectly on time. Thank you so
Great.
much, Heidi, for this talk and for presenting us all the risks of disinformation, information, and more specifically, how they happen actually, and the importance of the amplification you were talking about. I know that many people from the audience are from teams of social science around the network in Cambodia, in Madagascar, and elsewhere. So I'm counting on you to ask your question to Heidi. It's a huge opportunity because we are giving more and more importance to social science in the network. So please, the floor is yours. I also have some questions, but the priority is for the audience. Don't be shy. Noel, of course.
Yes, sorry. I'm absolutely not from the social network. I'm more a biologist, but I would like to react to 2 points that you said. In Africa, for example, you are talking about the situation in Africa, which was indeed controversial during COVID, because you remember that it was one vaccine which had been sent to South Africa and which was indeed not covering the virus which was circulating in South Africa, and which was then resent or reshared to other regions in Africa, in other countries in Africa. that found themselves as being served as a second hand, I can say. And it was exactly at the same moment where it was this sort of a special, how to say, special thinking of WHO to give some vaccine to Africa. And indeed, this vaccine arrived very late. In Guinea, for example, we received the vaccine only in, let's say, June 2021, which was largely after Europe, etc. So in Africa, it was a sort of a double vision. First, you provide us something which is that others don't want, first. And second, we receive the vaccine very late. So we would like to have them earlier. And finally, what you are given is not totally corresponding to what we wanted. So it was this sort of a controversial situation, which was evident here. And then I have a question. Why in your scheme that you showed that, for example, in Vietnam, in Asian country, it was less dislike of vaccine than in other places. When for what reason in Asia it would be different? You remember this scheme that you showed? You have
Yes.
Vietnam at the extreme left, which was something like positive at 15%
Yes.
of I don't, and then it became negative. Why would it be more acceptance, let's say, in this part of the world?
You know, how governments handled their COVID vaccine rollout really affected the general public sentiment around even childhood vaccines, because that figure was about perceptions of safety in vaccines in general, but the public was happy with how the government got vaccines to them during COVID. And that was what we saw, like in India too. Confidence went up around vaccines because the government, and the government they were also happy that the government said, I'm going to stop, Modi said, I'm going to stop exporting until I make sure that my whole population's covered. So those kind of things were trust builders for people, and not necessarily in other countries. Now, how long? I mean, we're monitoring all these countries because some of these will be, this research was in 2023. So that was just coming out of COVID. So we are continuing to monitor to see, was that like an immediate glow afterwards, but then it starts to go down again, or vice versa, whatever. Yeah.
Thank you, Noel, for your question.
Yeah.
Any other question? And by the way, Noel Tordo is the director of Institut Pasteur in Guinea.
Oh, great.
Who was actually, and Noel, please correct me if I'm wrong, who was mostly created just after Ebola, and so to have an Institut Pasteur in this country.
Indeed, the Institut Pasteur in Guinea was created because of Ebola. And so
Exactly.
we were just going out of Ebola that we went through COVID. So we were affronted to two, let's say, emergency in the region. But what I was saying was more the distribution of the vaccine at least in this part of Africa, which was late.
Yeah.
And at one moment, it was not the best vaccine that people can imagine. Because it was refused somewhere for excellent reason, because the mutants were not efficient to be covered by the vaccine, but it has been felt as a second-hand gift.
Yeah.
Okay, so we have a question from Osman. Please.
Hi, thank you very much. So I have a question about
I don't know if Heidi, can you hear him? Because we can't hear you well, Osman.
No.
Oh yeah?
No. We hear something, but we can't really hear you.
Still you cannot? Is it better?
No, not really. You will
Is
have
it
to
better
speak.
now?
Maybe you can
Yeah,
write.
yeah. That's much better.
Okay,
Okay.
perfect. So I was wondering if there is
Could you please
any.
introduce yourself, Osman, just to know where are you based?
Yeah, I'm at the Pasteur Institute in Paris. So
Okay.
I was wondering if there's any advisory groups apart from NETACs, specifically actually working on vaccine hesitancy in each countries, or how do they collaborate? I think where the break comes, where these countries actually go into a hesitancy is because of all these communications, miscommunications, and disinformations. And usually in the case of pandemics or a new schedule, it is not it is not communicated maybe enough in a way that actually what public requires to hear. So I was wondering how this is actually centralized, like from the perspective of WHO. How do they implement new strategies in terms of vaccine hesitancy, especially in these countries where the hesitancy is growing?
Sure. I mean, at a country level, the Ministry of Health is responsible for the immunization programs, and increasingly, they're increasingly recognizing the issues around vaccine hesitancy. It's different in different countries. WHO does have a couple people in headquarters who are particularly working on strategies, and I was part of the SAGE working group on vaccine hesitancy in 2013, where they asked us, I think there were 11, 12 of us, to characterize what's the nature and scope of issues and suggested strategies. But those were that was a decade before COVID hit. So there has been more of a consciousness, but one of the things that has become very clear is that it's even with the best information, it's not going to solve some of the issues. So as a basic foundational thing, you need to make sure people have the correct and adequate information in the channels that they listen to and trust. But it's really important to understand what else might be going on that could be affecting their hesitancy. Because sometimes they have a bad experience in a health clinic, nothing to do with a vaccine or whatever, and then they don't want to go back there. Or they feel like they've been stigmatized, or they don't speak, if they're a minority group, there's a language issue. So it's important but that typically is primarily supposed to be managed by the Ministry of Health, but UNICEF does a lot of work in this area. A number of the other groups are working on that. There is certainly, when I left UNICEF in 2005 to start this initiative, having seen around the world this growing issue, there was a lot of denial, and it's one of the reasons I left, because I said, we're not taking this seriously. And I knew until we started to measure it and start to get numbers and quantities, then they'll pay attention. But so anyway, and it does vary depending on the country. Some are a better place than others.
Thank you.
Yeah.
Thank you, Osman, for your question. We still have time for a few questions.
I'll put my email in the chat in case.
That's great. Thank you so much. Saren from Cambodia. Go ahead, Saren, please.
Hello, can you hear me?
Yes.
I have a question regarding the Sanofi dengue vaccine, because like the scandal is since 2016. So I was wondering if Sanofi did face some legal issue regarding the first launch of their first dengue vaccines in the Philippines, because there's like it caused like a huge public health trust in vaccination. It's not just about dengue, but it's also affect vaccination hesitancy with other vaccines as well. And it's an important lesson learned for not just for the Philippines, but also for some other countries in Southeast Asia. And how do the government try to fix this public health issues when it comes to vaccine hesitancy? It's kind of similar to previous question, but this one is just particularly for the Philippines and the Sanofi dengue vaccine. Thank you.
Sure. What's really interesting about the introduction of this vaccine, and I mean, this is an example of the social amplification of what was a very real small risk that unfortunately was confirmed already after like hundreds of thousands of kids had been vaccinated. And as I'm sure a number of you know, they just saw that there was a small risk that if you hadn't been previously exposed to dengue, not necessarily sick with it, but had some exposure, getting the vaccine might give you worse dengue. It would be, yeah. But that same memo, and actually the memo that they sent out was to relabel. It wasn't stop everything. It was like relabel and make sure or find out about previous exposure. In Brazil, which started the same time as the Philippines, there was no drama. They trained up their, they briefed all their frontline staff. They did change the labeling. The program was not discontinued. There was, of course, some hesitancy in the public following that news, but it carried on. So it's an example of how political context, and unfortunately, the Dengvaxia vaccine was introduced as kind of a legacy initiative by the previous president, who, a lot of kids die in the Philippines from dengue, and he thought this would be a great thing. And even WHO had recommended it. I mean, but then the new government was in place when the risk came out. So it was a huge opportunity for them to undermine the previous government. So again, the political context was something. They of course, had made court cases with Sanofi, but there's been so much drama and contention around it. But to the credit of the Ministry of Health, what they did is they saw, we had data, because we had confidence data before the Dengvaxia was introduced and after the initial reaction. They had a figure that absolutely showed with numbers about how much of a drop in public confidence in vaccines happened. And that apparently was in every meeting that anyone went to about dengue vaccine, we were told. But they used that data, and we worked with them to monitor as they were doing their trust building. They said, we're not going to focus on trust building in the vaccine. We need to work on trust building in the Ministry of Health, because they've lost confidence and faith in us for having recommended this. And so they did that, and there was another measles vaccine campaign coming up. So they made an extraordinary effort around the measles campaign to be engaging, to be trustworthy, to be, and then they continued that work, and they saw that our confidence index started to go up slowly, and that kept them motivated. So I think there's a lot to learn from that case, and there are a number of articles written about it. And what I think is particularly telling is this data we collected last year that showed they were more willing than any of the other Asian countries and actually Latin America was less willing. So that was frankly even a surprise to me, because even knowing that their trust was starting to go up, but that's to the credit of but it wasn't without a lot of stress and anxiety and drama, as you know well.
Thank you so much, Saren, for your question. We still have time for one last question. I have one, if the audience is okay with that, which is I don't know if the audience have a question. If not, I will ask mine. Okay, so I'll take it. I have a very broad question, Heidi, as a network, because you are here as a pastor network, and I would like to have your thoughts about how the pastor network could compose with this situation and how it could mobilize itself at the global and local level against this and misinformation. Well, it's a very broad question. There is no right answer, of course, but the idea is just what could be the role of our network?
I think it's a really important question, and you have an incredible resource in the network. I mean, I would be happy to think with you on if there were like a subgroup of people who, or as many as one, who are particularly interested in this, if any of them already have some any either examples of how they've dealt with it. I mean, one thing we could do is through the network find out, has anyone had to deal with misinformation? How did they do it? Are there any local resources that might be useful to other people, and pull together a kind of resource for countries to anticipate that. I mean, I think it'd be even interesting for us to have a longer meeting that really is people bringing their examples, or maybe when is the next meeting of the whole network? Don't you have your
It's
annual?
in November. It's in November.
Yeah. Maybe for that, or maybe in the meanwhile we can do virtually. Yeah. I think it would be really valuable, and maybe we start by putting together. I could do this with you, Hisham, a small just questionnaire.
Yeah.
That asks some basic information, and then we pull that together and then go from there.
We will do it. We actually we already worked with few members here on a questionnaire to map the capacity, the expertise on the network. But of course, we can add something on disinformation, misinformation, and there will be a specific space also as well.
Great.
For our social scientists to gather and to better know each other and to work together.
Yeah. Great.
But that was at the research level. But how do you think? What could be the role of a network like ours against this? I mean, this curse in a way, which is disinformation, misinformation, and especially with some high political people. Promoting fake news.
Yeah.
Yeah,
I think that's, and I wouldn't at all limit this misinformation, disinformation work to social sciences. I'm as you know, an anthropologist, but I wouldn't. I mean, anyone in any role is going to face this, and I think it's important that there's the different perspectives. I mean, even as Noel, he's not a social scientist, he said, and it's affected anyone in the group, whatever discipline they're coming from. Can be affected by this. I'm being called in more and more to give talks to really basic upstream scientists. I mean, Rockefeller University asked me to give a talk to them. Some of the people there were really traumatized by, some of the reaction that came to them when they were trying to identify strains of the COVID vaccine in the thick of what was going on in New York. And they said, here we were trying to do a service, and the vitriol that some of them faced was, so even in labs, people are depending on, particularly they were working on a hyper-political topic, but they don't think of it as being political, sitting in your lab and really trying to keep up with the pace of evolution of these strains. And so I think that what would be really interesting is to find out across from the different disciplines, where they've faced any challenges, if they've are aware of ways that have worked. And even through the network, you've got a fantastic network of listeners that, if something's popping up somewhere, especially these days with social media, it can spread like wildfire. So, and sadly, what's coming out of the US is not helpful at all. And that is also spreading around. But it gets more traction in some settings than others. But I do think that as a listening network, as a sharing network, and also coming up with, if we can get some resources that, because you all work with colleagues in your local settings. So that Pasteur could be seen as someone to turn to that can help, has some resources on managing these things.
Okay, I think we agree. Thank you. So it's just the beginning of a collaboration then.
Yes, yes, that's great.
Great. Thank you so
Okay.
much, Heidi. And
Thanks.
so I thank you to everyone for joining us. We'll see each other next month for the next monthly seminar. And until then, let's keep in touch. Thank you so much, and see you
Thanks.
soon.
Cheers.
Thank you.
Bye.
Bye.